the new term for a lot of young people and for the senior and the seasoned orthopedic surgeons, probably who have not heard about this term, is extremely important. Radio Synoviorthesis, RSO, simple terms, simple, very, very simple. And what is that? It is a simple term. RSO gives refer to a technique which is already there on the slide. I don't need to really read it, but I will just go on anyway. Now, we give into the joint a local application of a radioactive. It is not a dye, it could be, but it's a radioactive agent. But this is given in osteoarthritis. One, it is not just to relieve the pain nor the discomfort, but we need to improve the inflammation so that the patient who is receiving it gets a better, what shall I say, effect, pain-free, joint. So this is not a new technique, to tell you frankly. It's been there for a long time now. It's about 40 plus odd years now. Many of the orthopedic surgeons are not even born when this technique was stipulated. There are a few reasons why it did not take up in the big way in those days, because of the availability of the nuclear isotope, which was very, very restricted in many of the countries as well as in India. And we need to have a governmental, clearance to get those radioactive the agents into, because it's very highly radiating. So we have to be very careful in those things. Keeping that in mind, yes, back in the 60s, when Delabret talked about this entire thing, to restore the knee joint in a better way by injecting the radionucleotides into the joint to make it non-surgical, or probably a radiosynovectomy kind of a term which was nomenclated those days. And it was forgotten because of the availability of the centers in the country and the world as well. So let me run through that. Now, yes, the radiopharmaceutical industry has grown up in a massive way. As Dr. Jha mentioned earlier on, a PET, ordinary CT to PET CT to PET MRI, and a lot of things have been done. So keeping that in mind, what is that we use here? For larger joints, we have Atrium 90 and Rhenium and Erbium also available. But the majority of the joints which we talk about is into the knee joint today. So let us focus on the knee joint. Atrium 90 is the one which is being used in a big way. And what happens there? I mean, this colloidal injection causes the phagocytosis, which is already there, which Manish talked about a lot of things in the past, in his last few slides. And the changes which happen, what Abhay also talked about, in the condition, what happens with the pathogenesis, what Dilip talked. We try to give the injection, and when one injection is given, it forms a sclerosis or fibrosis. The synovial stroma, the villi, will be affected, and then it gets devascularized, and then the cartilage becomes thicker and pain-free for them. It takes a few weeks to months for that to get the effect. And yes, this is going to be just a bird's eye view for you people. Basically, the dose is variation because of the joint involvement will be different. And again, in the knee joint, we talk about 185 mega or 5 curie atrium to be given. And in a year, those cannot be increased, because like in a hyaluronic acid or a steroid, people have given repeated injections. But here, we need to be very specific and not to repeat too many times. So there has been a very clear-cut understanding on that. Let us not take too much time there. Now, we talk about the dosage. We came there. 185 we talked about. So that is where the knee joint atrium dose will be coming to. And what happens? Can we give multiple joints? Both the knee joints or single uni or bilateral can be given. It can be, but again, we need to assess the dosage as well as the patient's body structure, and then talk about it. So with that in mind, yes, there could be good results. There may not be that so good results. There are a lot of reasons for that, but we need to make sure how we can differentiate it and take it forward. The second dose also can be given in about probably 8 to 10 months time. And many a times when the osteoarthritis starts, people also have injected into the cyst, and it has regressed very, beautifully there. So the side effects, yeah, like in any drug, no drug is safe. So every drug is a poison in the true sense of the term. Even this has some amount of side effects. Being what shall I say, injectable kind of a thing. So we need to be careful about the infection, make sure all the sterile precautions have been taken care. And then I don't think there's a major issue, but except some neoplasm has been documented, but we need to look into in a larger study. Contraindication, obviously, because the knee joint osteoarthritis is not limited to old age. Younger people can come in. Even in pregnancy, people have seen this. So this particular injection cannot be given in pregnancy and lactation. So that's very, very clear-cut indication. And some of the conditions where we can indicate from rheumatoid arthritis, I know we are talking about osteoarthritis, because all these things can give us a secondary osteoarthritis. Hence, the list have been put here. So these are the kind of precursors where osteoarthritis of the knee can be seen. So this can be used. And special precaution with hemophilics, they should have a proper workup done. And now, the effect. We talk about how good is it. So naturally, we talk about the knee joint. 77% they have seen good results, and it's almost maintained that in the end of 2 years. So it is a very good thing to look into in the future. And definitely, there's a lot of study need to be done. Yes, there's going to be a lot of radiation comes into picture, so we need to be taking care of all those precautions, and the methods are also different, and how we're going to inject it and how we're going to dilute it. All those things have to be given. And one thing, as we talked about, any injection going into the joint can cause some amount of inflammation. And thankfully, unlike in hyaluronic acid, a steroid can be utilized to reduce the inflammation post radiation, or what we call it as radiosynoviorthesis. So that is the biggest thing. And the side effects we want to talk about, I think I'll leave it. It could be a simple infection. A joint infection is a very serious one. Simple, we have to be careful about. But we have to rule out the inflammatory response to infection. That has to be made very, very clear. That has to be differentiated. So that has to be worked out and clearly explained to the patient. And mind you, we have to have a proper counseling and consenting, and we need to have a regular follow-up so that patient gets a big, cheerleader for us. In the past, radiologists used to be doing all the work, the radio diagnosis. Today, thankfully, the radio diagnosis has been super specialized, so we don't need to worry about he or she being pulled in different directions. Thank you. Thank you. With this, I think I will probably end my slide. And thank you, Dr. Jha, and thank you, Shiva, Naveen, and everybody to give me a bird's eye view on the radio synoviorthesis, what we talk about. Hopefully, this should be able to give a precursor for it to do the future studies. Thank you.